एक सेकेंड, आ गए हम लोग यूट्यूब पे। अब आप देखिए। अरे सर दिखेंगे ना, वो पार्टिसिपेंट्स आ रहे हैं, वो दिखेंगे साइड में मुझे। वो तो मैसेज डालेंगे। हाँ, अभी तक लाइक्स 9 है, कंसर्न व्यूअर 6 लोग हैं लाइव। हाँ, और 10 लाइक आए थे, 6 लोग दिख रहे हैं, अभी देख रहे हैं। नहीं, वो तो मीटिंग होस्ट ओपन कर, हमको पता चलेगा।
ओके, तो आप सबको मैसेज भाई हमने सब मैसेज कर
सर अभी फिलहाल, हेलो सर, वी आर, सर हेलो,
Yes, Swapnil, tell me.
we are live now. So whatever we are talking right now is live everywhere on YouTube. So I suggest
Yes.
to do the mute thing. And now we are live. So right now there are 12 viewers who are viewing us right now.
Right. So I think we can start.
Yes, you can start, sir. Yes, we just waiting for the doctors, so we can start the officials. और सर आपके पीछे सब दिख रहे हैं, तो उनको थोड़ा सा। And hello.
Yes.
And on YouTube there is a delay of 15 seconds
Okay.
of video.
So the presenter will have to adjust to that delay.
No. You just go on. The viewers will see, so that's okay. You don't have to adjust anything.
Okay. So I think it's good to start.
Yes, we are start now, but we have only you are there, so we are waiting for other doctors to join.
But you said there are 12 people who already joined.
No, that the viewers.
So the other doctors are with me only on this computer only. As I said, we'll be doing it.
Oh, so okay. So yes. So now we go ahead. Please. Okay.
Yeah. So
I just do the formal introduction. Hello, everyone. Welcome on behalf of Rhythm Academy. And today we are about to start the session. So I hand over to Dr. Neerav Balani, MD, to start the procedures.
good afternoon, friends. Good afternoon, friends and colleagues. Thank you for joining us for this symposia, Rhythm Academics. Now, I think this is the new normal, and in the era of COVID, we'll be meeting more and more on the digital platform. As we all know, in Baroda, the COVID scenario is now on a downscale, and many of us are returning to our pre-COVID practice. So what good time it would be to discuss about the new normal, the cardiology in the COVID era. Rhythm Heart Institute has started functioning fully. Rhythm Heart Institute has a segregated area for a limited number of COVID patients. And we all know as doctors that the fear for visiting a doctor is much more. However, transmission of COVID from a doctor facility, doctor's clinic, doctor's hospital is much less than transmission of COVID in public areas like vegetable markets, grocery shops. But the patients are very much afraid of visiting a doctor's facility, and because of that there is a delay in treatment and delay in diagnosis, leading to complications. So as frontliners of medical practice, as general practitioners, we would have to instill the confidence in them to visit the doctor and take appropriate treatment. So today we have four eminent speakers. Dr. Anand Ahuja, an eminent cardiologist, who would be speaking about the cardiology in the COVID era. We have Dr. Tejas Kakkad, a pulmonologist, a senior pulmonologist who would have an experience of treating more than 2,500 patients of COVID in the last 6 months. And he has, to his credit, one successful ECMO patient. The patient could be was put on ECMO and could be weaned off successfully. We have our intensivist, Dr. Raviraj. Everyone knows him. He's one of the finest intensivists of Vadodara, and he also took very active participation in managing COVID. And he would be talking on right now what everyone is facing, approach to fever, because right now in the current situation with the COVID going down, all fever are not COVID. Fever, we have alternate diagnosis in the form of dengue is picking up. Some cases of malaria also we have diagnosed. So how to approach a case of fever would be taken by Dr. Raviraj. And Rhythm Heart Institute has started a urology department. Dr. Nishit is a young and budding urologist with very safe hands. He has done 4 or 5 surgeries at Rhythm Heart Institute in the post-COVID this thing, and he would be talking about approach to colic from a general practitioner's viewpoint. In between, if you have any questions, we would be putting it in the chat box, and we'll take it with the experts once the session is over. So without any delay, I would first invite our first speaker, Dr. Anand Ahuja, a senior and eminent cardiologist, who will be talking to us about the management of coronary artery disease in COVID era. Dr. Anand, can we please have you? Presentation चालू है?
Hello friends, I hope you can hear me very loud and clear. So I am your friend Anand Ahuja, and we talk today about the management of coronary artery disease in COVID era. Why is this a separate talk to be discussed about is what we'll see. So the agenda of our talk today is, where have the cardiovascular diseases gone? Are they there and they're not seen, or they're actually gone down? We'll also see what is the preparedness of practice in the COVID era. How prepared are we as doctors to take care of our cardiovascular patients? We'll see about the heightened cardiovascular risk, especially in the COVID era, which is also aggravated by the fact that the COVID infections increase level of inflammation and hypercoagulability and increase the susceptibility to cardiovascular disease. We also talk about tailored approach. How do we stratify risk so that we can safeguard our healthcare workers also and manage our patients also who can possibly have COVID infections along with. And we'll talk slightly about management guidelines and the role of intensive pharmacotherapy, because we will be delaying surgeries, at least the non-urgent surgeries. So in that case, pharmacotherapy becomes much more aggressive. So let's just first begin. Where have the cardiovascular disease gone? Have they actually gone? Really speaking, I don't feel so. It's just that there is a lack of mobility and lack of effort, so the diseases remain dormant and silent. Because conventionally we all know that cardiovascular diseases are aggravated by exertion, and if you don't exert, you will never get those symptoms. So they might still be there, the blockages would still be there, but you might just not realize the symptoms. It's just like if you have a car parked in the garage, you will not expect it to get a puncture. But does it mean the prevalence of punctures have gone down? No, it's just because the car is not used enough. There's also a fear to approach healthcare facility on the part of patient side, because they feel that there could be a heightened risk of COVID transmissions, and therefore they are really reluctant, and they try and resort to home remedies, and they do not approach healthcare facilities until it's too late. There is a lot of resistance on the part of the healthcare professional also in terms of thorough evaluation. We tend to talk to the patient on phone, try to treat him symptomatically so that we can actually avoid a physical contact, a physical examination, and a lot of things can get possibly missed in this particular thing also. There's a possibility of transportation issues also because of the impending lockdown, now that it's not there, but that also contributed, because movement of patients from their home or their residential areas to the healthcare facility, especially if it is in a different town or city, can get affected. Secondly, one more reason is the economic impact, because the COVID lockdown has affected a lot of people economically, financially, and this recession has kind of made people slightly averse to access healthcare facilities easily. They try to resort to cheaper or self home remedies and only access healthcare when it's actually unbearable for them. Another impact could be because of at the resistance. Even if they reach a tertiary care center, there could be fear from the patient side, from the healthcare worker side. Initially, there were a lot of restrictions in COVID testing also. There was a fear of quarantine, because of which people we saw a lot of patients who hid their symptoms, who masked their symptoms, who did not report their symptoms. So all these things contributed to a seemed or a perceived reduced prevalence, but actually I feel it is not actually there. The prevalence is still there, and it's very much there to stay, and we have to treat them aggressively. But for that, we first have to prepare ourselves so that we are safe ourselves. Only then we can safeguard our patients. I'm sure you all would have known about the levels of protection that are required. We'll not go into more details, but we all know that at the initial level, the primary level, the level 1 care will comprise of a simple triple layer mask and cap, a gown, a shoe cover, and gloves. That should be sufficient, something like this. Category A and B. A is for people who would directly come in contact with patients, and B who would not. Okay, like say security people. Level 2 is people who would need an impermeable gown, a triple layer mask, cap, goggles, shoe cover, and gloves. And category 2 would just require the similar things. So this is the category 2, level 2, category A and B level of PPE. And same way, people who are actually operating in the cath lab or working in ICUs will require N95 cap and mask, and will require double gloves, face shield, shoe cover, and a COVID-19 gown, something like this. I'm sure you all know about all these, so we won't go into more details. Of course, hand hygiene is very, very important. We all know all the 7 steps recommended by WHO. We all know the protocols for hand rubs and sanitizers, which should contain at least 70% of alcohol. We all are quite aware about the donning and doffing protocols also, so we will not go into more details. But I just recommend that, whenever you initiate practice or when you are full term into practice, try to screen your patients for COVID. Try to ask them to fill a form at the reception or at the entry point itself, so that you can screen patients who might relatively be asymptomatic or mildly symptomatic also. So try to check for patients who have symptoms of COVID, such as say breathlessness, cough, or low-grade fever, or who have a high risk, who have a contact with COVID positive family member or any other person, or who has a family history, something like that. So with a form such as this, which we used, we try to reduce or triage patients and identify them as high COVID risk and low COVID risk, so that you can address the risk substantially and you can segregate those two patients. This will also help in reducing the cross transmission at the healthcare facility. I'll not go into more details of donning and doffing protocols. We all are very well versed with that. So all these are basic necessities, which is a must for every healthcare worker when he resumes his clinical practice. Of course, we have now easily known that the caps and the masks can be reused. You can use them 4 or 5 times, and you can reuse after 4 days of drying them separately also. Now we talk about what is the heightened cardiovascular risk. There are a lot of factors. There is a lot of emotional stress, health stress, financial stress to the people, and that can aggravate cardiovascular disease. There is immobility, and that can worsen cardiovascular risk. COVID itself is a hypercoagulable state. It increases the levels of inflammation. People get dehydrated with fever during COVID, and all these can worsen any thrombotic events, be it acute coronary syndromes or stroke or venous thromboembolisms. All these can get aggravated by COVID. Plus, there can be a cross reaction also, like hypertension and cardiovascular disease, as we will see in some subsequent slides. So if you talk about any thrombotic event, COVID itself is a respiratory infection which causes a lot of inflammation, platelet activation, endothelial dysfunction, and vascular stasis. And this can predispose to arterial and venous thrombosis. These can be either a direct effect like endothelialitis, or it could be just indirect effect of inflammation and vascular stasis. And patients need to be on antithrombotic therapy for such reasons. And we have to understand the drug interactions between various antiviral drugs and antithrombotic drugs. We should know about their choice, the selection of the drug, the dosing of the drug, and the monitoring of such patients. Without much details, we all know that almost 80% patients are mildly symptomatic or asymptomatic, but the remaining 20% of the patients who have severe COVID infections can have significant coagulopathies, which is virtually in every patient who has a severe COVID infection. So we need to identify and treat these patients very aggressively. Moreover, some people can have concomitant venous thromboembolisms, which can account for a lot of unexplained deaths in these patients. So that also needs to be understood, that it could be simply a bystander also. If we want to see the underlying risk factors, there are like acute illness, ridden patients, stasis, genetic factors, fever and diarrhea, dehydrations. All these can predispose to vascular stasis and thrombosis. There can be hemostatic abnormalities like microthrombi in the pulmonary circulation, disseminated intravascular coagulopathy, myocardial injury, and all these conditions can lead to venous thromboembolism, can lead to myocarditis or myocardial infarction and DIC. And together, all these things can cause increased risk of arterial as well as venous thrombosis. So because of this, we have to consider a lot of aggressive anticoagulant and anti-platelet therapy in COVID infections. And we also need to take care of our non-COVID patients also, who should not feel ignored by any scope of imagination. So the guidelines recommend that all patients with significant COVID infections should be checked for D-dimer, platelet count, prothrombin time, and fibrinogen. If all of them are in the normal range, you need not really do anything aggressive, but they still need to be monitored as long as the COVID is there. If they are abnormal, if the coagulation markers are abnormal, you need to identify these patients and admit them and monitor them on a regular basis. And all these patients should be started on a prophylactic dose of low molecular weight heparin. If the markers worsen, then you should give them therapeutic doses also. So if a patient is low risk for COVID, if the acute coronary syndrome risk is high, then the treatment should be similar as guideline-based medical therapy for as per the ACS protocols. If the ACS risk is low, then you can be slightly conservative in your treatment and you can delay invasive procedures as long as the COVID stays. So you can wait for the COVID to recover and then you can look to aggressively intervene in coronary cases also. If the COVID risk is high, then you should be more conservative. If possible, if the patient is stable, if there is no ongoing angina, if there is hemodynamic stability, if there are no arrhythmias, then these patients can be carefully treated conservatively, and interventions like angiography and intervention can be used selectively in patients who remain symptomatic, who remain unstable, who have frequent arrhythmias, etc. So this is what is about risk stratification for acute coronary syndrome and venous thromboembolism with COVID-19. So all these patients need to be treated with anticoagulants. If anticoagulants cannot be used for some contraindication, then use intermittent pneumatic compressions. But all patients should be treated with low molecular weight heparins if they are not contraindicated. If the creatinine clearance is low, then you use unfractionated heparin drip, which can be stopped at any point of time should there be any risk of bleeding. And if there is any risk of thrombocytopenia and heparin-induced thrombocytopenia is suspected, then you should prefer to use danapiroids or argatroban or bivalirudin instead of fondaparinux or heparin. So regarding prevention, try to encourage hydration to all patients, especially those who have GI symptoms like diarrhea and fever. Hydration is very, very essential. Encourage people to keep moving. Even if they're isolated in one room, they should not stay bedridden most of the times and just stick to video games, but they should keep themselves ambulatory. Even that will help their mental health also. All medical illnesses and patients with moderate to high risk for thrombophilic states should be treated with low molecular weight heparin if they are not contraindicated. Patients who have trauma or who require surgery should also receive low molecular weight heparin. If the risk persists and the patient is discharged on OPD basis, even then low molecular weight heparins are to be preferred. But if they are not to be, if the patient finds them uncomfortable to take self-injections of low molecular weight heparins, then you can use novel oral anticoagulants such as apixaban or rivaroxaban. However, at the same time, you should keep a watch on creatinine clearance and drug interactions and avoid sedentariness and dehydration at all costs. This is very, very important. This is very basic. And regarding the use of antiplatelet therapy, all patients should receive aspirin before hospitalization. After that, you should switch over to oral P2Y12 inhibitors. You can use any one of them, like say clopidogrel, but out of all, ticagrelor is preferable because ticagrelor also has an anti-inflammatory activity, because it inhibits the ENT1, that is equilibrative nucleoside transporter 1, and this reduces the cellular adenosine uptake, and it has a potent anti-inflammatory property. Because of that, ticagrelor is preferable, and especially patients who have pneumonia can have ticagrelor can reduce complications of sepsis and reduce lung injury also. This we have seen that 20% patients who are critical, have severe illnesses, can have a very high mortality like 2.5%. Regarding severe COVID illness and comorbidities, we can see in the chart here that cardiovascular disease, diabetes, COPD, and hypertension account for most of the risk for complications and death. So people who have cardiovascular disease or diabetes or hypertension can have the highest chances of mortality in COVID infections. So these comorbidities also help you in identifying high risk patients who can have adverse outcomes, and these group of patients can be selectively treated very intensely or very aggressively. So if you can see, there is a big difference in the prevalence of survivors and non-survivors for patients who have hypertension, diabetes, smoking, and COPD and coronary artery disease. For patients who have cardiovascular disease, the case fatality rate is almost 10.5%. For diabetes, it is 7.5%. For COPD, 6.5%. Hypertension, 6%. It is much more than even malignancies. So these patients have a high mortality rate when they face COVID infections, and therefore they should be very aggressively treated. Why this happens is basically because of the angiotensin 2 receptor type 1, because this is the main receptor which is involved in the internalizing of the coronavirus to inside the cell, and that then leads to multiplication. And these are overexpressed in cardiovascular disease, in hypertension, and that is why you need to have angiotensin receptor blockers. They can be quite useful sometimes. Without going to more details of pathophysiological or molecular basis, I'll just broadly say that cardiovascular manifestations are myriad. People can get cardiac toxicity with antiviral drugs. People can get myocarditis. People get heart failure. People get cardiac arrhythmias also because of severe COVID infections. And the main reasons could be because of the common pathophysiological basis through the angiotensin 2 receptor type 1. Or it could be also because of the cytokine storm and release of interleukins 6, 17, and maybe other pro-inflammatory cytokines. We'll not go into more details of the pathophysiologic basis, but patients do have a heightened inflammation, increase in the risk of myocarditis, myocardial damage, as well as vascular stasis. And all these can precipitate cardiac injury, can worsen hypertension, can worsen COVID-related myocardial damage, and worsen aggravate heart failure. Symptoms of also cardiovascular disease and breathlessness occurring because of COVID can be very similar, so that can also be a lot of source of confusion. We'll not go into more details how do we identify them, but your pre-test probability, your index of suspicion should be very significant. So whether it's a confirmed case, probable case, suspected case, or a negative case will help you identify whether the patient's symptoms are more likely to be due to cardiovascular involvement or they're because of COVID infection. We'll not go into more details of that, but we all know that your protection is important whenever you have an access. Whenever you see such patients in the ER, try to first of all assess the risk for COVID. If it is no COVID, you will treat as per standard protocols and guidelines. If COVID infection is possible, likely, probable, or confirmed, then your guidelines would be slightly altered. First of all, you have to ensure whether you are able to safeguard yourself and maintain good levels of protection for your healthcare workers while you are treating these patients. If that is not possible, it's safer to refer this patient to a facility where this can be taken care of so that you can safeguard your own staff. And if it is possible, then you should try to be conservative. Regarding coronary artery disease, if it is a STEMI, if the patient is stable, you can safely thrombolize, go for thrombolysis. It's only when a patient is unstable, has cardiogenic shock, has hypotension, has significant LV dysfunction, has ongoing angina, or has arrhythmias, only in such situations, or when thrombolysis is not possible, in such cases, you should go for invasive intervention, or these patients can be referred for or can be tested for COVID first and then go for interventions once they are declared to be COVID negative. Same things can be treated, can be done for valvular heart disease, for arrhythmias, as well as other infections. For non-ST elevation MIs or unstable angina, also you try to categorize patients as very high risk, intermediate risk, and low risk. Of course, very high risk and high risk patients will require urgent invasive procedures. So there is no need to defer them. You can continue. For low risk patients, you can continue conservative treatment, and intermediate risk, you can tailor-made based on their symptoms, their troponin levels, and their GRACE scores. So try to identify patients, try to treat them conservative, and refer to a COVID care facility where COVID can also be managed and cardiovascular diseases can also be managed effectively and safely. So this is the basic dictum of COVID management. Regarding the guidelines for therapy, thrombolysis, same guidelines as before. Antiplatelets, same guidelines. Anticoagulation, same guidelines as before. However, the doses should be more stringent. And also try to look for other chronic coronary syndromes very aggressively. Try to use echocardiography or CT angiographies, etc., if that is possible, or sometimes if invasive procedures are not possible due to whatever reasons. Acute heart failure, again, the managements will remain the same. Only thing is that the outcomes would be more grave. There are more chances of inflammation and sepsis, lung injury, kidney injury, and hypovolemia. So they should be kept in mind. There are higher risks of arrhythmias and myocarditis, so that should be considered. Pulmonary embolism is also very high risk in COVID patients, so they need very aggressive anticoagulation with low molecular weight heparins. And remember about, if you are using warfarin, they should consider that there can be drug interactions with antiviral drugs also. Hypertension should be aggressively treated. There are a lot of patients who have aggravation of hypertension also during their COVID infections, and they should be treated with aggressive therapies. Calcium channel blockers are absolutely safe, but if a patient is already on ACE inhibitors and ARBs, they should not be stopped because that could be more dangerous. New onset arrhythmias also should be treated with the same guidelines as previously, because arrhythmias could be life threatening and we need not be any lenient because of COVID. So, we'll not go into more details. The points to conclude is that basically you first try to safeguard yourself. Try to triage patients whenever they come to you, whether they are at high risk for COVID or low risk for COVID. If it is low risk for COVID, try to treat as per the same protocols. And if it is a high risk for COVID, then you identify which patients can be conservatively treated. For high risk patients, of course, there is no substitute. You have to go for early interventional treatment. And for moderate risk patients, you can initially stabilize them, treat their COVID, and then send for interventions. This is how you can safeguard both yourself as well as your patient also. Thank you very much. That should be sufficient. So I hope that was quite intuitive. If you have any further questions or queries, I will be most welcome to address all your questions, which you can type in the chat box. And for the next talk, I invite Dr. Ravi. Yes?
There's one question from Dr. Nilesh Shah, which is
Yes.
there on the chat box.
All right, I'll just see and address. We can take all the questions in the end also. Dr. Raviraj Singh Goyal can complete his talk and then we can take them. Sure.
Hello. Am I audible? Hello. Good evening, everyone. Myself, Dr. Raviraj Singh Goyal. I am intensivist here. Thank you, moderator, for this important topic, approach to fever in a COVID era. Because since 8 months we are doing COVID, and we have to also think about out of COVID box. So we are trapped in the COVID box. Each and every fever we are diagnosing and reach to the diagnosis of a COVID. Okay. So we have to think about out of COVID. So any medical specialty are now COVID specialist, and we become a COVID this PhD in COVID from the University of the WhatsApp and Facebook. So is it actually it is the right thing, right to get new knowledge from the social media, but what to follow and what not to follow, that is very important from this guideline. COVID share epidemic potential. Rather, I will tell it is definitely it is now pandemic now. So as such in India, there is some epidemic prone disease in a seasonal pattern like dengue, malaria, seasonal flu like H1N1, leptospirosis, chikungunya, and scrub typhus. It is also a possible thing in this season, pre-monsoon or post-monsoon season, and also enteric fever and hepatitis also. So it may present alone or coexist with the COVID. So we have to think about that. It may lead to clinical and laboratory diagnostic dilemma and difficult to diagnose and reach to the diagnose and how to manage. There is some kind of restriction of management of with co-infection with other disease. Okay, so if we are seeing for fever for 2 or 3 sentence, it is a symptoms, not a diagnosis. First we have to remember. Okay, so what is the fever? It is a rise of normal body temperature. If we take a normal body temperature is 36.5 to 37.5 centigrade. If higher than that, it's considered as a fever. In ICU, in IDSA or American Society of Critical Care, this defines the fever in ICU is more than 38.3. But if in general community, if more than 37.5 is a fever. So most of the time we have seen if fever is a bad or fever is a beneficial. Yes, obvious. See, fever is a beneficial thing. It indicates our immune system is competent to fight antigen or fight some virus or bacteria. Okay, so it is a complex physiological, protective, or adaptive response to some antigens, whether it is a bacteria, virus, fungi, or any kind of parasite. It's maybe a non-infectious also. See, some kind of pathology like pancreatitis or DVT, or even central like hemorrhage or even trauma, it's may causing the fever. So we have to also rule out some non-infectious cause of the fever. Yes, is beneficial, definitely it is beneficial, but in some extent, if out of that extent, if there is a fever, then we have to treat. So it is important to establish the cause of fever in relation to the clinical presentation and sign and symptom in the COVID era. Okay, so remember, not all fever is COVID. Yes, there is a era in India in 1999 when I taken as a this MBBS admission. At that time, the clinical situation is there. Any fever considered as a malaria. Okay, so any new onset, acute onset of fever considered malaria and give the empirical malarial treatment. Right now it's the same. So any patient came with the fever just as a COVID, so it is not right thing. We have to rule out some known COVID febrile illness. So let's see. See, WHO given a definition for the COVID. It is definitely sensitive, but it is not specific. If there is a symptom is there, then consider as sensitive. If there is a no symptom, okay, then we cannot rule out that there is a COVID is not there. Okay, so seasonal epidemic prone disease may be present as a febrile illness with that mimic the COVID, and also may be present with the COVID, and there is a lead to the difficulty to diagnosis. Epidemic prone disease, like in see in India, there is a geographic region variability during monsoon and post monsoon season. So there will be some malaria, dengue, or leptospira or scurf typhus also maybe prone to in this season. And yes, bacterial co-infection must be suspected in moderate to severe cases in which the COVID is not responding to our treatment. So in that case, we have to suspect the bacterial infection. So it is a definition. See, acute onset of fever and cough, or acute onset of more than 3 or symptoms like fever, cough, fatigue, headache, myalgia. So it is a very vague definition. It is not a specific definition. So we have to think about, so there is maybe some overlapping sign and symptoms with this other disease like dengue or malaria. Okay. So what are the suspected co-infection? So there is a dengue, malaria, chikungunya. So see, in this season, if the any patient is diagnosed as dengue or malaria by lab, so we cannot rule out there is no COVID. Or in some patient like COVID is positive, we cannot rule out dengue or malaria is not there. Okay, so we have to rule out dengue, malaria, chikungunya if the patient is not responding to treatment or maybe worsened. Like seasonal flu in the winter season, now winter is coming, post monsoon season, so seasonal flu like H1N1 season is also there. So we have to also rule out the H1N1 in the patient of COVID also, or negative COVID also. Leptospira is same like in post monsoon season, there is a season of leptospira. Scrub typhus, generally it is in the hilly area or Himalayan areas is there, but there is also case in the Panchmahal or this type of the geographical region. Hepatitis or enteric fever, it is maybe a foodborne or some waterborne disease that occur in the post monsoon season. So what is the diagnostic test that we have to see? This all our diseases are antigenically distinct, but sometimes symptom is overlapping. There is a definitely test is available for diagnosis of each and every case, but sometimes there is a overlapping or the false positive or false negative test is there, because there is a some less sensitive kit is available, or there is kit is not maintained on the cold chain proper. So there is a guideline from the ICMR. If you want to do the COVID test, then follow the ICMR guideline RT-PCR. If you want to test the dengue, malaria, or chikungunya, follow the National Vector-Borne Disease Control Program test only. And if you want to diagnose seasonal flu or typhus or lepto, then you have to diagnose the according to the National Controls this disease center. Okay, so these are the tests. I'm not going to detail, but I am telling dengue. If you want to diagnose the dengue early, then always test with the NS1 ELISA only. Okay, don't do the IgM in early case. After 5 days, you can do. Chikungunya is IgM is okay. For H1N1 COVID, RT-PCR is sensitive around 70%. Malaria, rapid diagnostic test or slide is important. Leptospira, IgM is okay. Scrub typhus, we are doing IgM, scrub typhus and bacterial co-infection. We are sending blood and urine culture. Okay, so managing co-infection, it is very challenging. Okay, so sometimes what happen, COVID is there and there is some secondary infection is there, so there is a presentation is similar and overlapping. We cannot diagnose it is a COVID or it is a dengue, malaria or some other things. It share the pathogenicity. Some most of the disease like tropical, all diseases are share the pathogenicity like the COVID. Diagnostic difficulty, yes, sometimes is dengue. So we'll see in the dengue slide. So diagnostic overlapping is also there, and limitation in treatment option. If someone have a COVID and also dengue, then it's very difficult to treat. Okay, let's see. See, COVID and dengue pathogenesis is similar. So there is a cytokine storm, okay, and there is a chemokine storm, and there is a viral vasculopathy or coagulopathy. So pathogenesis is similar. Clinical feature diagnosis, almost initial dengue patient came with the this malaise or fever or see, that is important thing is that respiratory complaints is more in the COVID, and hematological like bleeding and that complication is more in the dengue. Okay, so that is a main important thing in the diagnosis. What is important in diagnosis? If someone have a COVID positive, okay, and if we done the IgM, dengue IgM, then definitely it's maybe a cross positive. There is evidence cross positivity in the dengue IgM in early 5 days. So in that case, we have to do the ELISA NS1. If someone have a COVID positive and it is the first 5 days, then do the dengue ELISA NS1 antigen for the to see whether dengue is there or not. Yes, specific therapy if someone has a COVID and patient have a also dengue, then definitely treatment is a fluid therapy. Important thing is that in that case of fluid therapy, if there is a no COVID, then we can give the fluid resuscitation or free fluid we are administrating. But in case of the COVID, we have to do the restrictive fluid therapy. If patient is in the shock, definitely give fluid therapy. But if patient is not shock, then we have to restrict the fluid therapy to prevent lungs. Okay, LMWH, yes, in COVID, there is a definite role of the LMWH because of hypercoagulopathy. But in case of the dengue, there is a low platelet count. So we have to restrict the LMWH and antiplatelet as per the coagulopathy. Use of corticosteroid, yes, we have to give the steroid because it is dengue is a viral illness. And there is some evidence the viral in the dengue, the steroid will work, but it is not a evidence based. But you can give the steroid. In case of the TOSI or antiviral, there is no need to change because of this co-infection with the dengue. Continue with the TOSI and antivirals. Okay, in the dengue. Now in the malaria, see, we all know the pathogenesis because of this all the PYX, malaria, oval, or this falciparum. So this leads to the hemolysis and that make the organ dysfunction. I'm not going to be so much of pathogenesis, but yes, diagnosis, we have to do the diagnosis according to the this national guidelines for rapid diagnostic test and this slide test. Clinical feature is definitely overlapping in malaria present with the flu-like illness, severe headache or this nausea or vomiting or maybe the diarrhea, okay, and fever. So important thing is that clinical feature we have to rule out according to the these complaints. Specific therapy, anti-malarial we have to give. I am not going to detail in anti-malarials, but malaria is not so much of the diagnostic difficulty with the COVID. Yes, leptospirosis is see, it is a one type of zoonotic disease. It is also a very contagious disease in the animals because of infected urine of the these cattle or in the these rodents. Okay, so main important thing is a pathogenesis. It is the vasculitis. So each and every organ affected by the vasculitis and leads to leaky capillary syndrome like the COVID vasculopathy. So clinical feature generally this is present as a Whale syndrome or some it is present with the asymptomatic case to the fatal syndrome. Okay, so clinical feature, all the clinical feature, fever, malaise, myalgia, these all are same like COVID, but main important thing is a conjunctival suffusion. This is very important, this landmark sign of the leptospirosis. So diagnosis, this, as we said, as per national guideline, lepto-IgM is very important test for the diagnosis. And management concern, we can give doxy and ampicillin and amoxicillin in case of the children, if the doxy is the not indicated on the children. Okay. Like in the scrub typhus, see, scrub typhus is right now I have diagnosed one case in the rhythm only presently, scrub typhus. See, in the COVID era, we rule out all the COVID and rule out each and every dengue, malaria, hepatitis, and after that we diagnose the scrub typhus. Simultaneously, we sent all this panel and diagnosed the scrub typhus. Patient came from the Dahod, periphery of the Dahod. So pathogenesis is Orencia tutsugamishi. This is a one type of pathogens, is a gram-negative bacterium that leads to the scrub typhus. So diagnosis we have done with the scrub typhus IgM. There is a rapid test available as per national guideline. Clinical features same like the present with the malaise, fever, or a headache, and mostly patient with the 3 to 22 days of the incubation period. Okay, generally patient present with a one bite mark, then a maculopapular rash, and becomes a specific one type, the central necrosis and the eschar form of the lesion in any type, any part of the body. So that is a diagnostic point. In our patient also, there is a one spot on the lower part of the this flank on the left side. Okay, so treatment concern, doxycycline or macrolides, or most of the time doxycycline and macrolides is enough to treat. Rifampin in case of the resistant case we can consider. Okay, enteric fever also we have to rule out. Same presentation like COVID. Patient has a fever, patient have a thrombocytopenia, leukopenia, patient came with this nausea, vomiting, diarrhea, same like COVID. So we have to diagnose. We see this time presently we are not doing any patient Vidal test. Vidal is now obsolete, so we are doing the typhoid IgM ELISA to diagnose for the enteric fever. And for treatment concerns, ceftriaxone, quinolone, azithromycin, that is a simple treatment. Yes, this is a very important side for the seasonal flu. See, right now seasonal flu season is coming. So most of the time what happened, COVID and simultaneous H1N1 case or seasonal flu is now increasing. So most of the time what happened, which virus is generally occurring with the co-infection? So RSV virus, enterovirus, and influenza A virus, or maybe H1N1 virus. So in winter season, if there is a COVID, and if COVID is the seronegative but CT is positive, then we can consider as a H1N1 RT-PCR we have to send. There is a similar pathogenicity like the influenza-like illness or severe acute respiratory illness. Clinical feature and diagnosis same like COVID. We can send a RT-PCR is available for the H1N1 cases. This is very important thing. Specific therapeutic consideration, antiviral, it is available for the H1N1 cases. Oseltamivir, as such, we are using in the routinely in the H1N1 case. So there is a definitive treatment is available if there is a COVID negative and still you are thinking this is a viral illness and CT is suggestive it is a viral illness, then send H1N1 immediately. But it is in the winter season. If there is a summer season and there is no any this type of that virus is not circulating in your environment, then don't need to sell this. COVID and bacterial infection, there is a small proportion of the evidence that bacterial infection is prone. Most of the time community acquired or hospital acquired super infection is there. Most of the time mycoplasma, pseudomonas, or Haemophilus influenza, Klebsiella pneumoniae, maybe because of UTI or vape or skin soft tissue infection. Yes. So if this COVID patient is not responding to your treatment, and then you have to send all the blood culture, urine culture, procalcitonin, and then you have to treat according to with the antibiotic. But yes, consider the antibiotic as per local antibiogram. Don't give each and every patient of COVID antibiotic. Yes, if your patient is high risk, your patient is elder age with comorbidity, then start with the antibiotic according to your this antibiogram. So these all are we discuss this non-COVID febrile illness. So if you are treating your primary center and if patient is worsening, then immediately you have to refer to the tertiary care center like in our hospital. So altered mental status or systolic blood pressure is 90, mean arterial pressure is less than 20% of baseline, hypoxia, respiratory compromise or respiratory failure, persistent high temperature, decreased urine output, or some kind of bleeding in case of the dengue or malaria case, you have to immediately send the patient to the tertiary care center without wasting much time. So in case of the prevention, yes, basic preventive measure like SMS, the social distance, mask or sanitization. Out of that, we have to prevent this local gathering or some type of regular these updates or awareness. In case of the this malaria or dengue, we have to do the vector control, protective cloth and repellent. Yes, for the this scrub typhus or malaria or dengue. Yes, vaccination is important. Still, vaccine is not available for COVID, but here for seasonal flu, according to the seasonal pattern, we have to take the vaccine. In case of the this elderly case, we have to give the vaccine in the January, February, or post this monsoon status. Yes, community involvement is the very important thing. Community awareness is the main key to prevent all this disease, and integrated surveillance. We have to notify all the disease like dengue, malaria, COVID also. So conclusion is there: alert, vigil, and high index of suspicion and constant awareness of the possibility of co-infection. See, in this season, don't think only about COVID. Out of COVID, we have to think, so that help the physician avoid the adverse outcome of case with the co-infection and improve clinical outcomes. Thank you very much. We can take a question just after all the session. Yeah. Okay, so thank you very much all. I am inviting Dr. Nisarg Mehta. He is the this urologist and taking a lecture on the colic pain for the general practice. Thank you very much. Yeah. આપણે સર થાય તો ડાયગ્નોસ જે આપણે લેક્ચર કરતા હતા
Hello, good evening, everyone. My name is Dr. Nisarg Mehta, and at the outset, I would like to thank Rhythm Heart Institute for this talk. I hope everybody is safe and healthy. And today I'll be talking on managing colic in general practice. So, what is the most painful condition a human being can feel? Pain, as we all know, it is a very subjective thing. Some people, they can tolerate huge amounts of pain, whereas some people are so sensitive that they cannot tolerate even small amounts of pain. So this is a list which was recently published in June of this year by the National Health Service UK, and kidney stones was considered one of the most painful conditions to a human being, next to almost labor pain or pain because of dental extraction. The pain because of kidney stones has also been described by Hippocrates as an acute pain which is felt in the kidney from the loin to groin, and gradually the urine is suppressed with passage of sand in urine. Gujarat, as we all know, it is falls under the stone belt. About 12% of Indians generally suffer from pain because of urinary stones, out of which 50% of the population is severely affected, leading to damage to the kidneys. Stones, they can be classified by a variety of different things. Stones can be classified as infectious stones or non-infectious stones, stones due to certain genetic disorders, and stones which are produced due to certain drugs. Stones can also be classified according to their characteristics on imaging, that is an X-ray or a CT scan, according to their location or according to their composition. Typically, the presentation of patients with urinary stones is flank pain radiating from loin to groin, or dull aching pain with intermittent episodes of colic. The pathophysiology as such is that the pain is produced because of stretching of the renal capsule, which occurs because of obstruction, and secondly, peristalsis of the urinary tract against obstruction also causes similar pain. Along with pain, symptoms such as nausea, vomiting, fever, lower urinary tract symptoms strangury, etc. are all presentation and complaints of patients with ureteric stones. So coming to the investigation part, all of us know that the ultrasound is one of the best modality and one of the first choice investigation which is done in patients with ureteric colic. However, we should all be aware that the sensitivity of ultrasound as such to pick up a ureteric stone is quite less, around the range of 45 to 50%. So always an ultrasound has to be combined with a plain X-ray QB so as to avoid this limitation of the ultrasound. Recent guidelines, they say that a non-contrast CT QB or a plain CT QB, it is considered the gold standard, and it has replaced ultrasound X-ray QB for diagnosing patients with ureteric stones. Ultrasound as such, the limitations because of bowel gas are overcome by this newer diagnostic modality. Other benefits of a plain CT QB are we would also get information about the density of the stones in the form of Hounsfield units. It will give us information regarding the skin to stone distance, which will all help us to select the modality of treatment which we can offer to the patients. Also, in patients with ureteric stones, there is temporary renal shutdown. Hence, an IVU or a CT IVP will show a delayed functioning kidney. So, plain CT QB is considered the gold standard modality for diagnosing these patients. A very common condition which is faced by gynecologists as well as urologists, diagnosing imaging or ureteric colic during pregnancy. As we all know, radiation causes teratogenic as well as carcinogenic effects on the fetus. Hence, ultrasound is the only modality which can be offered to diagnose ureteric colic in pregnant ladies. A renal Doppler with changes in resistive index can help us primarily to diagnose ureteric colic. One needs to be aware that normal physiological dilatation of the ureter may also mimic ureteric colic as well as hydronephrosis in pregnant females. A second line option for diagnosing these patients is an MRI. However, gadolinium contrast has got to be avoided, and MRI should be done in machines with 1.5 Tesla rather than 3 Tesla. So coming to the best medication for patients with renal colic, a large number of medications have been studied and have been reported in literature, starting from intravenous lignocaine, various types of NSAIDs, opioid analgesics, antimuscarinics, calcium channel blockers, alpha blockers, etc. However, the drug of choice is NSAIDs as well as paracetamol, which are found to be the most effective in patients with acute stone pain. It has been seen that NSAIDs, the requirement of rescue analgesia or other analgesics is much less as compared to paracetamol or acetaminophen. So these patients are less likely to require further analgesia in short term. However, one should be very cautious in giving NSAIDs like diclofenac or ibuprofen in patients with congestive heart failure. Studies have shown that about 65 to 70% of the patients, they respond by reduction of pain as early as in 30 minutes. So NSAIDs as such, they work in two ways in reducing renal colic. They decrease the production of arachidonic acid metabolites, which mediate pain receptors, which is caused by distension of the renal capsule. They also cause contraction of the efferent arteriole, which leads to reduction in GFR and reduction of hydrostatic pressure across the glomerulus. Paracetamol, on the other hand, it inhibits prostaglandin synthesis, and it also has a central effect because it inhibits endogenous cannabinoids, and consequently they have their analgesic effects. As such, paracetamol is well tolerated, and the side effects as compared to NSAIDs are less. So for patients with ureteral stones who are being treated conservatively, oral NSAIDs like diclofenac sodium 100 to 150 milligram per day for 5 to 10 days can reduce inflammation and can reduce the risk of recurrent pain. In patients who have got severe colic, the NSAIDs can be given in the form of intravenous route or in the form of suppositories. However, one has to be very careful in patients with altered renal function. Diclofenac can affect the renal function in patients who are already having some sort of renal insufficiency. Hence, one has to be very, very careful in administrating NSAIDs in patients with altered renal tests. Coming to opioid analgesics, as such, they have a very good effect in patients with ureteric colic. However, they carry a large number of side effects in the form of nausea, vomiting, lightheadedness, respiratory depression, and hypotension. And they are less effective as compared to NSAIDs like diclofenac to reduce pain. So commonly, the second line medication or the medication used for ureteric colic is tramadol, 50 milligram or 100 milligram. And in those patients who are not relieved with this, the other agents like butorphanol 2 milligram or pentazocine, that is 1430 milligram, can be used. Another group of drugs which is anti-muscarinics like buscopan or rotavirin has been known to have an effect in reducing renal colic. They basically block the action of acetylcholine at the parasympathetic nerve endings and produce dilatation of the ureters. The side effects are dryness of the mouth, facial flushing, dry skin, constipation, as well as urinary retention. Rotavirin also is known to have its antispasmodic effect by inhibition of phosphodiesterase 4 receptors in smooth muscles. However, studies have shown that addition of antispasmodics to NSAIDs like diclofenac does not result in better pain control. There are certain other drugs which are being used for treatment of renal colic. For example, infusion of aminophylline, that is 2 ampule of aminophylline, which is mixed with 500 ml of dextrose or normal saline over a period of 8 to 12 hours, cause suppression of pain. And the mechanism of action is it causes increased intracellular cyclic AMP and reduces inflammation. Other agents like intravenous lignocaine as well as acupuncture are limited data as well as conflicting results are seen. Other medications are alpha blockers, that is tamsulosin 0.4 milligram or alfuzosin 10 milligram or silodosin 8 milligram. The greatest benefit is seen in patients with small ureteric stones less than 5 millimeter as well as ureteric stones in the lower ureter. Other drugs like combination of corticosteroids with alpha blockers, phosphodiesterase inhibitors like tadalafil, and calcium channel blockers like nifedipine are being used in various combinations for medical expulsive therapy. However, the data as such is insufficient and the regular use of such drugs is not routinely recommended. A very important topic is that is there any clinical utility to intravenous fluids as well as diuretics, which is a very common practice in management of renal colic. However, according to a review by Cochrane in 2018, the use of diuretic as well as intravenous fluids did not show any clinical benefit in the in form of time of to stone passage or the need of surgical intervention or in reducing pain. Hence, there is absolutely no evidence to support empiric use of fluid therapy to flush out the stones in patients with ureteric colics. However, patients who are dehydrated or who have severe vomiting, intravenous fluids can be given, and these patients can benefit because of hydration. So prevention of definitely prevention of calculi in the form of adequate fluid intake, maintenance of urinary pH, especially in patients with uric acid stones, a balanced diet rich in vegetables and fiber, reduction or having a calcium content to about 1 to 1.2 gram per day, and limiting salt intake, as well as exercise and balancing of excessive fluid loss is helpful in prevention of recurrent ureteric and renal stones. So the indications of active stone removal and indications of patients in which medical expulsive therapy or conservative treatment has to be stopped is patients who have a large stone burden or the size of the stone increases, patients with recurrent or with high risk of stone formation, obstruction combined with infection, that is patients presenting with septicemia or anuria, patients with symptomatic stones and having refractory pain, large stones more than 15 or stones with less than 15 if observation has failed, preference according to the patient or a social situation, for example, patients with pilots, etc. So to conclude, NSAIDs is the drug of choice in patients with acute ureteric colic. For investigations, ultrasound has always got to be combined with an X-ray QB to diagnose patients with ureteric stones, or a plain CT QB, which is the gold standard investigation in these patients. A big no to intravenous fluids or the flush therapy or diuretics in these patients. Approximately 90 patients of the stones less than 5 routinely pass within 4 weeks with any sort of medical expulsive therapy, and stones with less than 8 generally are impacted and require an intervention to pass. So which brings me to the end of my talk. I thank you very much. Thank you for being patient and listening to me. I wish all of you a very happy Diwali. Stay happy, stay safe. Thank you. I'd like to invite Dr. Tejas Kakkad for his next talk on his experience of COVID patients.
Thank you, everyone. I would like to talk about our experience of treating COVID patients at Rhythm. There are lots of COVID patients we are seeing now in our day-to-day practice, and we learn from our experience that we have to think faster than the COVID if we want to make our patient survivors. If we want to avoid post-COVID fibrosis, then we have to think faster, we have to act faster before COVID-19 virus can act. So we will discuss some interesting case. The first case, it was on the admitted on the 20th of October. She was a case of 50-year female, presented with high-grade fever, sore throat, body ache for 5 to 6 days. HRCT chest was suggestive of CT score 10 by 25, which is approximately 40% of the lung is involved. At admission, temperature was normal, SpO2 was 97 on room air, and the RT-PCR for COVID was sent. Initial blood investigations, CRP 8.1, D-dimer 518, ferritin is normal, LDH is also 281, interleukin 6 is little bit on higher side, still it can be considered as a normal or near normal. This was the HRCT plate on admission. Now day 1, there was a vitals, the temperature is normal, SpO2 is normal, there is a mild coughing with expectoration, RT-PCR was positive, methylprednisolone was started, low molecular weight heparin was added. Day 2, temperature is normal, saturation remains normal, CRP D-dimer within normal limits. We continue with the same line of treatment, and this was the day 3. Patient looking toxic, there was a generalized weakness, a temperature is around 100, 101, saturation is getting down to 95 on room air, ECG suggestive of sinus tachycardia, the pulse rate is around 140 per minute, there was a shivering with palpitation, uneasiness, and feeling of breathlessness. Interleukin 6 was 135 and procalcitonin was absolutely normal. So at that point of time, we decided to go for a tocilizumab injection with the consent of the patients and patients' relatives. We explain about the risk-benefit ratio. We also explain about the utility of the tocilizumab in current era, and patients' relative give consent for the same. Injection remdesivir also started. We have started with the low molecular dexamethasone because patient is having a severing with methylprednisolone, and we continue with the low molecular weight heparin. Day 4. So day 4, after giving tocilizumab 24 hours, temperature is normal, saturation is remain 96 on room air, patient improved, feels better, there is a no fever spike, there is a no dyspnea. So we continue with the remdesivir, dexamethasone and low molecular weight heparin. Day 5. Again, patient remains stable, D-dimer is also good, CRP is good. Continue with the same. Day 6. Patient is getting stable and stable. Remdesivir 4th day. This was a day 7. Again, saturation is 97. So patient started initial phase of cytokine storm. At that point of time, oxygen level was only 95% on room air. So before patients start on oxygen, patients develop ARDS, patient will put on NRBM or BiPAP. We start thinking beyond the COVID-19. So we act on the right time. We give the tocilizumab at the right time. We take all the necessary precautions, and ultimately patient is happily discharged. So right action at right time is important. I will discuss about case 2. It is again a very interesting case. The case of 63-year male with a history of fever, dry cough and weakness for 2 to 3 days. There was no any past major illness. RT-PCR is positive with moderate viral load on 2nd of October. Vitals normal, SpO2 is 97 on room air, temperature is normal. Initial blood investigation, CRP was 41, D-dimer 378. Ferritin is very high, that is 1154. So there are many studies where ferritin level is more than 1000, the mortality ratio is very, very high. So this is very alarming. Ferritin level is high. So this was in our mind that this patient may expire also. So the oxygen level was 97 on room air and LDH is 353. Day 2, there was a temperature spike around 100, saturation getting down 88 on room air, procalcitonin was normal, interleukin 6 is around 32. We started with the oxygen support, 6 liter, paracetamol was given, methylprednisolone was started, low molecular weight heparin started, HRCT thorax done, and there was 25 to 30% was the lung involvement. Remdesivir is also started. Now the day 3, sorry, there was a saturation is 96 with 4 liter of oxygen, temperature is normal. We get for Foley's catheter because while during passing patient get more breathlessness. Remdesivir is continuing, methylprednisolone is continuing. We have added nebulizer xylocaine for the coughing. Low molecular weight heparin is going on, and there was a strict proning. Day 4. So again the CRP is 28, D-dimer is 682. The oxygen requirement is still not decreasing at this point of time. So we decided to go for a plasma. Though plasma is not a proven therapy, few of the American studies especially deny for the plasma. But if you use plasma at early phase, like patient is on 1 or 2 liter of oxygen or very mild ARDS, so at that point of time, if antibody is there in the body, that will definitely prevent the further lung damage. So we started with plasma, methylprednisolone is going on, other nebulization is going on. Day 5. Again, the oxygen requirement is getting down, patient saturation is 95, there was a mild cough with expectoration. We plan for second unit of plasma, remdesivir 4th day, methylprednisolone we are tapering down, continuation of the low molecular weight heparin. So day 6, patient is on room air around 94 saturation, on deep breathing it's getting 95, 96. Day 7, so patients it's stable 96 saturation on room air, and there was a one episode of severing. Total count was 21,520, and ferritin is also getting down to 778. So despite of the higher blood count, that can be because of high dose of steroids, and there was a catheter also. So we decided to go for a piperacillin tazobactam antibiotics. Follis catheter was removed, and we taper off steroids. So day 8, patient saturation is 97 on room air, and finally patient is getting stable. It was a time for discharge. So the plasma at the right time, the tocilizumab at the right time in the case 1, which may can change the game. So we have to take the right action at right time. So this will be the case 3. He is a 56-year male presented with high-grade fever, generalized weakness, uneasiness, and sore throat. The temperature was 100, saturation was again 88 on room air, pulse is tachycardic, blood pressure is normal, respiratory rate is normal. RT-PCR was done, and which was positive, and HRCT was suggestive of 20% of lung involvement. So this was the day 1. At that point of time, saturation is 96 with 2 liter of oxygen, temperature is on higher side, CRP is also on higher side, and the most alarming, that is interleukin 6, that is 449. So we started with the methylprednisolone and paracetamol. This was a day 1, and we are taking just a simple observation. But the patient was not responding. The saturation oxygen requirement is increased, 96 with 4 liter of nasal prongs, then again 90 with 4 liter of oxygen, started with NRBM, then again on NRBM he is desaturating. So we decided to go for a tocilizumab. So we gave tocilizumab, we gave 1 unit of plasma, we started with remdesivir, we started with methylprednisolone in the higher dose, that is 125, 4 times a day. So this was a day 3. Day 3 patient was on BiPAP with 100% of FiO2. The saturation is 96. So pulse was around 100, and temperature is now normal. Respiratory rate is under control. CRP is still on higher side. D dimer is on little bit higher side. So we continue with the plasma, remdesivir, methylprednisolone, and heparin. Day 4. Now patient started improving because we take the right action at the right time. Tocilizumab was given within a time. So now patient started improving, 96% saturation with 10 to 12 liter of oxygen. CRP is now 65. Total count is increased because of steroids. We started with the higher antibiotics. Day 5, patient again improved, 96 saturations with 6 to 8 liter of oxygen. Remdesivir, Piptaz, methylprednisolone is going on. On day 6, again patient is improving, 97 on 6 liter. Day 7, 97 with 4 liter. Day 8, 97 with 1 liter. And day 9, we could have able to discharge the patient. So in all these 3 cases, we need to understand that definitely there are lots of things going on about the COVID-19. Which thing is working and which thing is not working, that we are not sure. But if you can take the right action at the right time, before the lung damage or before COVID-19 things, if you can think in a faster way, definitely you can save the patient, you can save the life. If you are acting late, then you may lose the patient, that is the first thing. And even if patient survives, he is dealing with, or she is dealing with post-COVID fibrosis, and which is very a painful condition. There are few patients who are unfortunate, who are on still home oxygen therapy, and even on slightest activity they got breathless. So we have to be very aggressive. We have to make our decisions. We have to take our experience into account. Tocilizumab is working if you can use it at the right time. Plasma is working if you can use it at the right time. Remdesivir is definitely working. Methylprednisolone and heparin, that is already proven drug since 6 months, 7 months, and we are using it in each and every patient. But the most important thing is right action at right time. Thank you so much, everyone. Any questions, please feel free to ask me.
Thank you, dear friends, for this. Hello. Yeah. Thank you, dear friends, for this excellent session. During this session, we had a couple of questions popping up. The first question was from Dr. Nilesh Shah, and the question was, how long should we oral anticoagulants continue after COVID discharge? See, the answer would be depending on the D-dimer levels. If the on-discharge D-dimer is high and the patient has been started on a oral anticoagulant like a apixaban or a rivaroxaban, you should normally we continue for 2 to 4 weeks and we monitor the D-dimer levels. Once the D-dimer levels touch to baseline, we may discontinue it after 2 to 3 weeks. Otherwise, till the D-dimer levels are within normal range, we should continue. Rarely, we might have to continue it for more than 1 month. Now, we have one question for Dr. Raviraj, and Dr. Mukesh Ahuja has questioned him. If the patient of COVID or dengue has thrombocytopenia, what is the role of anticoagulant like an LMWH heparin in that patient? Dr. Raviraj, if you can guide.
Yeah, that is a good question. Definitely, COVID and this dengue is difficult to treat in a way of fluid therapy and in a way of the coagulopathy. See, if the platelet count is permeable to give the antiplatelet or this LMWH, we can give. If any case platelet trend is, we have to daily repeat the CBC means platelet count. PT, APTT, INR. We have to do the APTT in the dengue patient because there is a loss of coagulant factor. So we have to do the APTT and we have to do the platelet counts. If the trend of the platelet count is gradually fall down, so in that case we cannot give the heparin. Or in case of the heparin also, always give the LMWH rather than the conventional heparin. So conventional heparin is more likely due to the this heat, heparin induced thrombocytopenia. So don't give the conventional heparin if you want to give LMWH. Yes, if the platelet count is rapid declining and if it's less than the 75,000, then don't give the this LMWH in dengue patient. And if there is a bleeding patient, if patient platelet is this 1 lakh and if patient have still bleeding hematuria or in case of this melena, so don't give LMWH or antiplatelet. So that's the conclusion. Yeah.
Yes, Raviraj sir, there is
Yeah.
one more question. Can a post-COVID patient develop herpes zoster?
Okay, so I said that there is a strange question. See, there is a not any data on that that leads to some other viral disease potentiation, but there is some data from the Thailand. In that they have also recorded to the WHO also. In that case, what happens is zoster. This herpes is also a viral illness. These are varicella zoster virus. That is a cutaneous disease, dormant. See, like TB, it is also a one type of the dormant pathogen. So whenever there is a less immunity in the patient, so COVID does what? Primary decrease of the immunity. Second, if we use the TOSI, then there is a low immunity. And if we use the steroid, then also there is a decrease of immunity. So these three factors leads to the potentiation of the other viral illness. So that is low immunity that leads to the herpes, but not COVID potentiate that. Okay. Yeah.
Thank you, Raviraj bhai. I think Doctor, one more question to go, Raviraj sir. I think fever is the flavor of the season. So from Dr. Dhaval Shah, we have two questions. One, loss of taste and smell post-COVID, how long it can last? And the second question is, are these HRCT changes of COVID reversible? And when should we repeat an HRCT?
That is the most common question as the layperson also they are asking. So first this question answer is that there is a very mild symptomatology, the loss of the taste and loss of the smell. Okay, so that is a very mild symptomatology. See, most of the patient, lots of patient I have also treated from here on the phone call. So they are almost at 2 to 3 weeks. So 15 days is the duration. So there is no fixed days, but up to 15 days patient have a no taste or no smell. So that is one thing. That is no any reason. That is maybe because of some nasal congestion or the loss of the ciliary activity. Okay. Second is definitely always the radiological clearance is always lag behind the clinical this improvement. So in not in COVID, but in any pneumonia, if patient has developed ARDS and patient is being improved, so in that case also the CT scan also lag behind than the clinical. If patient went to the home after 1 month, also patient have some kind of patches into the lung. But when to do repeat, that is more important. So if you recovered from the COVID, if you had a repeat fever episode, second thing, if you have a decrease the saturation level from the baseline, third, if you have a persistent cough and new development of the cough, And fourth, if you have a reduced activity, this capacity, then you have to do the repeat this HRCT. Otherwise, don't do any routine repeat CT chest to see the improvement for at least 6 months. Yeah, thank you.
We have uh, we have a question for Dr. Tejas. What are the role of the, we know that COVID, remdesivir is one of the proven therapy, steroid is one of the proven therapy, but there are a lot of experimental therapies, and everyone has their own experiences and positives and negatives about them. So we have a question regarding two such experimental therapies. One is methylene blue. What is the role of methylene blue? And second is Fabiflu? Is Fabiflu really effective? So we can have Tejas throwing some light on these questions.
Okay. Thank you, Nirobhai, and thank you, Dr. Rajesh Bhatt, for asking such a wonderful question. Definitely, the Fabiflu, that is Favipiravir, which was initially researched for the H1N1 pneumonia in Japan. In recent era, because the COVID-19 was a new virus and everybody was trying with the new antiviral, and they have tried with the Favipiravir also. There are little bit data which proves that Favipiravir is effective. So since so many doctors are still using it, and it has lots of side effect like increased SGPT level, increased uric acid level. There are lots of tablets, and in our practice we have initially used Favipiravir, but now we stopped and we are saying a big no for Favipiravir. Another thing is methylene blue. One of the doctors from the Bhavnagar, he suggested methylene blue, and he was using as an antiseptic for tuberculosis also, and he found the wonderful result with methylene blue also. We have tried with IV methylene blue, we have tried with nebulizer methylene blue, and we have tried with methylene blue drops also. Actually, to be very honest, I am not sure whether it is working or not. There are no side effects if G6PD is normal. We have tried in 10 to 15 patients and we didn't see any dramatic result with methylene blue. So still it's difficult to say. But if yes, patients' relatives demands for the methylene blue, then we can think of methylene blue. But as a doctor, I will not recommend methylene blue for my patients.
Thank you, Dr. Tejas. As always, Tejas is very crystal clear about his ideas, yes and no. There is no beating around the bush. I would like to thank all the participants. I would also like to thank my panel of expert doctors, Dr. Anand Ahuja, Dr. Raviraj, Dr. Tejas Kakkad, and Dr. Nishit for such an informative session. And hope this becomes a new normal and we meet more frequently on this platform. Thank you all. I think you will hear from us very soon. Thank you.